Hello, everybody, and welcome to our TIF Talk Tuesday. I'm Andrea Millers with Endogastric Solutions, and we're so happy to have you here tonight. We have a very special guest here with us, as well as before I introduce our special guest, I will introduce Lynn McFadden, who is one of the market development managers here at Endogastric Solutions. She will be helping us today. So before we start, I do want to remind everyone that's watching, this is a live event. So anytime, if you have any questions for our special guest tonight, please feel free to type it into the little chat section there, and we'll do our best to answer all of your questions this evening. So without further ado, I do want to introduce our special guest, Dr. Ramon Morales. He is a general surgeon at Coteau des Prairies Health System in Sisseton, South Dakota. He received his Doctor of Osteopathic Medicine and completed his residency in general surgery at the University of Medicine and Dentistry of New Jersey. Dr. Morales specializes in laparoscopic, vascular, and general surgery and is fluent in both English and Spanish. Welcome, Dr. Morales, and thank you so much for being here with us today.
Hi, thank you for having me. I appreciate it.
Fantastic. So we always start the program, kind of talking about what is GERD. So I'm going to give you the opportunity to explain to everybody watching today, what is GERD?
Okay, sure. Well, GERD is basically chronic acid reflux. I mean, all of us throughout our life will have bouts of acid reflux. We all know what that is, heartburn, right? But if you're having it 2 times a week or more, then it's classified as GERD, which is gastroesophageal reflux disease. So that's what GERD is.
Okay. What kind of symptoms would a patient be suffering from if they had GERD?
Well, there's a wide variety of symptoms. They can go from the obvious heartburn, chest pain. It can exacerbate asthma. You can have a cough, excessive hiccups or burping. You can have issues with silent reflux, which can occur at night, where a patient will wake up with a dry cough, sore throat, metallic or sour taste in their mouth. So those are the kind of things that you're looking at as far as symptoms for GERD.
Right. And I like that you kind of called it silent reflux. We get a lot of people that think heartburn is just kind of that initial feeling of pain in their chest, if you will. And a lot of patients present with other things, even voice change or whatnot. We talked to a lot. Yeah, go ahead. What were you going to say?
Well, actually, I have a patient who's a singer here, and they have noticed because of their reflux that their singing voice is affected. So yeah, absolutely.
Yeah, and sometimes they talk about LPR. So it'll be good to kind of walk through this. And if anyone has questions about that, please feel free to ask today. What do you normally recommend patients to do initially when they start feeling kind of this continuous, acid reflux or GERD?
Well, some of the things that patients could do initially is they can watch their diet, tailor their diet away from acidic foods, milk, tomato sauces, salsas, spicy foods, and so on. Stay away from chocolate, caffeine, avoid smoking, obviously, stop smoking, stop alcohol. That's all going to help. And actually, moderate exercise will help as well with acid reflux symptoms as well. So not only does it decrease your fat, but it will help you with your GERD as well.
Yeah, so all the good healthy stuff, right?
Absolutely, all the good healthy stuff. Yeah.
Is there anything, that you recommend for people? I suffer from, terrible acid reflux as well. And at night, you hear some physicians say, put blocks on your bed, try to eat at certain times. Are there things like that you recommend for patients?
Well, yeah, we don't want to eat large meals before we go to bed. We probably want to give ourselves a couple of hours before we go to bed after a meal. And even, when you eat a large meal before bed, not only can that give you acid reflux, but, even drinking water can cause more acid reflux after you eat a large meal and then go to bed. Water in itself shouldn't cause you acid reflux, but in that type of situation, it can.
Right.
I have a patient as well, several patients that have to use 3 pillows and prop themselves up. So they're on the schedule. They're on their schedule on the schedule to get a TIF, and that's
Oh,
a
good.
good that issue. Absolutely.
Fantastic. So you just mentioned the TIF procedure. Why don't we talk a little bit about, after they kind of diet and lifestyle modifications, what's the next step if they're still suffering from continuous acid reflux?
Well, the next step is medication. We want to put them on either an H2 blocker or a proton pump inhibitor. H2 blockers are like Pepsid. Proton pump inhibitors are like Protonics, Acifex. So we want to try and control their symptoms with medication. But of course, we don't want patients on these medications for a long period of time. Long-term PPI use has been linked with a lot of medical issues, kidney issues. It's been linked with dementia. It's been linked with a higher risk of fractures. Some metabolic disorders like hypomagnesemia, which is low magnesium levels. So we want to low B12 levels as well. So we don't want to keep patients on medications for a long period of time, but that would be the next step. Try and control their symptoms with medications.
So how often or how long, we get this question a lot from patients, how long should someone take, PPIs or H2 blockers? What's the recommended time frame that they should do that if they're having an episode or whatnot?
Well, my personal opinion is I'd like to see patients on it for 3 to 6 months to see if we can control their symptoms. And then if I can get them off of those medications, I will attempt that. And if they have recurring symptoms, I would consider that refractory acid reflux or refractory GERD, chronic GERD.
Yeah, perfect. Thank you. And then I have one more question, then I'm going to pass it over to Lynn. I see some questions popping up that from our viewers, so we'll get to those in a second. Before we do that, I'm not reading the questions yet, but it might answer some of them. What are the diagnostic tests that a patient would have to go through, to determine, are they a candidate for something beyond medical therapy?
Well, there's several different tests that we want to see. The obvious one is we want to do an EGD scope or esophageal gastroduodenoscopy. We want to take a look at the anatomy. We want to take a look at the esophagus, take a look at the stomach. We want to rule out that the patient doesn't have a bacterial infection called H. pylori, which increases acid reflux, increases acid symptoms, and can lead to gastric carcinoma. So routinely do a biopsy of a portion of the stomach called the gastric antrum to make sure that the patient doesn't have H. pylori. So that would be the first step. You can also see inflammation of the esophagus. We want to make sure that we're looking at the transition point between the esophagus and the stomach to make sure that there's no Barrett's esophagus, which chronic acid reflux can cause. Now, Barrett's esophagus is a change in the inner lining of the esophagus that can lead to esophageal carcinoma. So that's why we're so concerned about that. And really, that's why we're so concerned about acid reflux.
Yeah, perfect. Thank you. I appreciate that. I'm going to pass it over to Lynn. I see some questions popping up. Lynn.
Absolutely. Thank you. So we have Haley is asking, I believe I have a small hiatal hernia. Am I still a candidate for the TIF procedure?
Absolutely. Absolutely. We would have to go in and fix the hiatal hernia. And that's done with minimally invasive surgery, laparoscopic surgery. That's using a camera and long instruments. You get 5 small incisions about the size of your thumbnail. And I go in and I repair that at hernia. And then we proceed with the TIF procedure after that.
Wonderful. Thank you. My wife is a teacher. Her ENT says that her GERD is being caused by having to push her words out and talking loud through a face mask all day. Her PPI drugs that he put her on aren't working. What would you suggest?
So if her acid reflux is not controlled with medications, I think that definitely would need to do an upper EGD scope to take a look at her anatomy. I think if that's inconclusive, you'd move on to do what's called an upper GI, where you drink some contrast material that highlights on x-rays, and they take some x-rays and see how severe the acid reflux is. And if that is inconclusive, you can always do manometry studies, which actually tests the lower esophageal sphincter, the muscle at the transition of the esophagus and the stomach, that is supposed to close shut so that you don't have acid reflux into the esophagus that causes these symptoms. We can test that pressure out with manometry studies, and we can also do pH studies as well to identify how severe acid reflux is. So that's what I would say. Yeah.
Wonderful. Thank you for that wonderful advice. Joanne is saying too, she has a very large paraesophageal hernia plus GERD. What type of surgery would you recommend?
So with the large paraesophageal hernia, I would definitely recommend to repair that, and that can be done laparoscopically. If it is a large defect, I would probably put a piece of mesh in there as well to decrease the chance of recurrence. And then I would proceed with the TIF procedure.
Wonderful, thank you. As you can see, we do hear a lot of questions regarding the hiatal hernia and the presence of that and how that impacts GERD and reflux. And so very much appreciative that you're explaining that so well. We have another question here. Are your patients able to stop taking PPIs after the TIF procedure is done?
So I think the studies show about 98 to 99% of patients can come off of their acid reflux medications. We've been very lucky with our patients. I would say we've been doing this for about 8 months, and 100% of my patients are not on acid reflux medications anymore, and they're symptom-free. So they've been doing very, very well. I'm very.
That's fantastic. Yeah. That's great to hear.
Yeah.
That's wonderful to hear. Is there anybody in particular, Dr. Morales, that kind of stands out to you? Any patient that you've recently spoken with that shared a great story that you would like to share?
So what I've noticed, and my patients have done very, very well, and I'm very happy for them. But what came to as a surprise to me is that I've had a couple, maybe 2, 3 patients tell me that this actually helped their mental health.
Wow.
They feel so much better. And I think it's just the chronicity of acid reflux and just the fact that you have to watch what you eat, and you're having these symptoms and probably not getting real good sleep, and patients just come in and they're just bright-eyed and feeling really good. And I'm just so happy about that. And that's what it's all about for me is my patients. So yeah, it's been great. And that really stands out to me, how a patient can tell me that, wow, I think this really helped my mental health. That's fantastic. Yeah. Absolutely.
Yeah, absolutely. Wow. That's excellent. That quality of life, we hear that too. It's so impacted by this. And absolutely. Not everybody realizes.
And when you have a chronic condition, you just learn to live with it, right? You don't realize how sick you feel. And it happens with a lot of different types of issues and diseases. But so I think that once you realize that you didn't feel that great and now you feel great, it's such a big difference. You know what I mean?
I think that's the change everyone keeps asking, like, Andrea, why haven't you gotten your TIF yet? Why haven't you gotten your TIF? And I'm like, I'm so busy. And I think about my GERD every single day, right? Because I'm like, I can't eat. I have to eat before this time because I want more time. So when I go to bed, I'm not dying, and I wish I knew that feeling of after having it, so I can say, let's get in there and do it sooner than later, right? The thing. So, I think this is part of it, educating people that are listening and watching and maybe thinking about doing something other than just continuing to stay on PPIs. I do see a question here about what exactly is the TIF procedure from Kim. So I knew you were going to go there. So I was going to kind of transition to that. Sure. Can you talk a little bit of what TIF stands for, and then, what does it mean and how does it work? And then maybe compare it also to what are the different other surgical options that are available today.
Sure. So a TIF is a transoral incisionless fundoplication. Basically, we're creating a fundoplication or a wrap utilizing a device, the esophagus device, that goes into the mouth, down the esophagus, into the stomach. So we're actually doing this within the GI tract instead of from outside of the GI tract, like a laparoscopic Nissen fundoplication. Laparoscopic Nissen fundoplication, basically what you do is you go in and you dissect out the stomach, free the stomach, you fix a hiatal hernia if there is one there, you pull down the esophagus into the abdomen, okay? And then you wrap the stomach around the esophagus, the junction between the esophagus and the stomach where the lower esophageal sphincter is, and it creates pressure at that point. So it helps the lower esophageal sphincter keep acid from refluxing into the esophagus. Great procedure. We've been doing it for a lot of years. But there are issues with it, as with any procedure. You know, the dissection is much more intense and complicated doing a laparoscopic Nissen fundoplication. Then of course, there's no dissection to consider with the TIF, except for the hiatal hernia repair. So I think that's why I chose to do the transoral incisionless fundoplication. I think that you're not changing the anatomy, you're actually reinforcing and repairing the original anatomy. And I think that's what attracted me to the TIF procedure. And I think that's why it works so well for our patients.
Perfect. Thank you very much. And we just got a question from Jeffrey asking, my gastroenterologist says I should consider surgery, but I keep reading Lap Nissen has a lot of side effects. What are they? And does TIF have the same side effects? So maybe you can explain a little bit of that.
So there's a lot of different ways to wrap the stomach. You can do a 360 wrap, which is completely all the way around. You can do a toupe, which is a 180. There's also like 270 wrap. But most of the main complications that patients get with this type of the laparoscopic Nissen fundoplication is patients have issues with dysphagia, or they feel like they get food stuck at the area of the wrap. So that's one of the big problems with day-to-day functioning. Then you have to start tailoring what you're eating. Sometimes these wraps can slip. Of course, you can get a recurrent hiatal hernia repair, and then the wrap will be up into the chest, and there's a different pressure gradient there, and that will cause you to have more acid reflux or recurrent acid reflux with this type of procedure. Again, it's a great procedure, but I think that the TIF definitely has a better profile as far as complication rate. I think the complication rate is 0.5% issues. My patients, in my personal experience, my personal practice, the first week there is a feeling like there's something there that patients will tell me, but I have not had anybody with food actually getting stuck in their esophagus or having that what we call a bolus sensation, a feeling like there's something stuck there. So I have not seen that in my practice.
Yeah, thank you. So can you talk a little bit about the recovery part of it? Because I think that's a very important part of this, journey of getting the TIF procedure and allowing yourself to heal appropriately and taking your time and your food. Can you talk a little bit about what that protocol looks like post, whether it's hiatal hernia and TIF procedure or just the TIF procedure?
Well, I think that, and I tell my patients it's the most important part. I think the post-TIF diet, following the post-TIF diet, is probably the most important part of the whole procedure. Yeah, the doing's great. Doing the procedure is fantastic, and getting the procedure done is fantastic. But sticking to that diet, making sure that you do heal, making sure that you don't go home and eat a hamburger that first day home and then just undo all the work that has been done. And then you end up kind of in the same place again with chronic acid reflux. So again, I tell my patients that that's the most important part, and I emphasize it every time I see them. And they've been doing very, very well sticking to the diet. It's clear fluids for the first 2 weeks. We kind of break it up in threes. So for the next 2 weeks, it's a little bit more solid food. The third 2 weeks, they're going into almost a regular diet, kind of a soft diet. They've had very good results, and they've had a very easy time actually sticking to it. And so they prepare everything. They get a blender, getting ready for their procedure. They're very motivated, and yeah, it's been going very well as far as that's concerned.
Fantastic. Yeah, I've heard from a lot of patients, it's good to get prepared with all of what you're going to eat before your procedure. Now, one question I do have for you, do you have them get off of PPIs before the procedure, a week or two before?
No, I don't do that. I stop their PPIs the day of surgery.
Okay.
I haven't had a patient that has required to go on a PPI after the TIF procedure, but I don't want them to have symptoms, and I don't want them to have a severe bout of acid reflux and have esophagitis or inflammation of the esophagus, which would be a contraindication to performing the TIF procedure.
Sure.
Or potentially possibly an ulcer, which would be another contraindication for the TIF procedure. So I do keep them on until the day of surgery, and then they don't return to the medications at all.
Wow, fantastic. Yeah. Lynn, are there any other questions that have popped up? I haven't had a look.
Yes, we do have a couple more. One is Chad's asking a twofold question. Does insurance cover the TIF procedure? He has Blue Cross Blue Shield, and his friend has Medicare with a supplemental. I'm sorry. Yes, and his friend has Medicare with a supplemental.
Well, I can tell you that we haven't had any issues with insurance carriers for this procedure. We've had quite a wide array of insurance carriers for different patients. So I would say yes, this is covered by insurance, absolutely.
Wonderful.
I'm no insurance expert,
right.
but I know my patients haven't had any difficulties, right?
Great.
So that's
Perfect.
great. Yeah.
No, it's a great answer. We always encourage on these episodes that folks should really look at their insurance and ask those questions too. So thank you for that. The second part of Chad's question is also, would I have to have the manometry test before I have the TIF surgery? I'm a little nervous that I wouldn't be able to tolerate that.
So you don't necessarily have to have the manometry test. A lot of different docs do a different type of workup. If I see significant evidence that you're having acid reflux or you're having significant symptoms and your upper scope, the EGD scope, does not show a stricture or a narrowing at the lower esophageal sphincter, you don't necessarily have to have the manometry performed or even a pH study. So that would be an individual physician type of thing. I recommend just talk to your physician or talk to your surgeon.
Excellent advice. Thank you. Then Dennis has a question. What's the length of time the procedure lasts before something else can be done?
Before something else can be done? Like
I'm thinking he's just asking longevity of the TIF procedure.
Okay. The studies that are out right now have shown pretty good results, I think, past 5 years. Of course, the TIF hasn't been around real long, so we're still working on that. So I think that the jury's kind of still out on that. Again, the immediate effects are fantastic. So.
Excellent. And with any other procedure, there's potential for redo. But with TIF, what would your advice be as far as the way you're going about doing that procedure and the advantages of that if a redo had to occur down the road?
Well, I think that you're not, so again, the dissection is not very complicated for a TIF procedure. When you get into a laparoscopic nisophilduplication type of situation, you've dissected a lot of the stomach away from its attachments, and you've really done a lot of work on the anatomy. So going back and doing a repeat or a recurrent hiatal hernia repair or a slipped Nissen, trying to redo those is technically very complicated. I think with a TIF, doing a recurrent acid reflux, going back in and restructuring that valve again, I think that would be technically much more favorable to do. So again, the dissection, the length of surgery, the potential for complication is much less with a recurrent TIF procedure.
Wonderful. Dennis, I hope Dr. Morales' answer addressed your question. Andrea, there are a couple more. You want me to keep going?
Sure. Yeah.
Okay.
Yeah.
So we didn't touch on this too much, but you did speak about the potential dangers of long-term PPI use. But what are some of the potential dangers of untreated or unmanaged GERD and leading to other more serious health conditions?
Well, like I kind of touched on earlier, I think chronic GERD, severe acid reflux will lead to changes of the esophagus, to the inner lining of the esophagus called Barrett's esophagus, and can eventually lead to esophageal carcinoma. I just recently read an article that esophageal carcinoma is in the rise, on the rise. There's more cases of it. So again, that's why we're so worried about acid reflux, and that's why we're so concerned. Again, everybody has bouts of heartburn here and there every once in a while, but if you're having it 2 or more times a week, that's chronic GERD, and that you need to see your physician about that, because that can lead to devastating issues afterwards.
Right, early detection, early prevention, early cure. It goes along with, John had a question about Barrett's, and if he has Barrett's esophagus, can someone still have a TIF procedure?
Yes, Barrett's esophagus does not exclude you from having a TIF procedure. In fact, I would recommend to see somebody about an acid reflux surgery if you're having that severe of acid reflux that you're having an issue with Barrett's esophagus. And not only that, but you will need surveillance EGD scopes to take a look at that area, possibly perform biopsies. Not all physicians will perform biopsies to diagnose Barrett's esophagus. That's not necessary all the time, but we definitely want to keep surveillance, and we usually want to take a look, depending on how severe the Barrett's esophagus is, every 1 to 3 years, and that will be up to the physician preference there and what they find.
Okay, excellent. Thank you. Andy's asking, my doctor told me I should get a Nissen or a toupee, and that TIF wouldn't be right for me. I'm not sure what to do. I'm getting different answers and feeling not confident about next steps or what is best.
Okay. Well, what I would say is get a second opinion, get a third opinion. I always encourage my patients, hey, if you're unsure, the last thing you want to do as a surgeon, or at least that I want to do, is take a patient to surgery that's unsure or has doubts. So I would say get a second opinion, get a third opinion. I mean, I can't speak for another physician. I don't know why they would say that, but again, talk to some more docs and get the whole picture and get the whole idea of what's going on and what their thought process is, and ask more questions. Ask a whole ton of questions. I love that. When a patient comes in with a list of questions, that's a motivated patient, and that's what's the greatest patient to operate on, is a motivated patient. So that's really good.
That's excellent. Thank you. And then last one for now, Andrea, we have Dennis asking, he's just responding to his earlier question about the length of time for a TIF. He said, I asked because I had a procedure where a twist was put into the esophagus, which lasted 20 years, and now I'm back on the purple pill, he says.
Oh, okay.
For Dennis.
Okay, so I'm not sure exactly what procedure he had, but yeah, so it's kind of difficult for me to say.
Yeah. And he's back on the purple pill. Wow.
Yeah.
Go see your doc and get an upper scope done and see what's going on with your esophagus and your stomach for sure.
There you go. Well, thank you for getting those questions in, Lynn, and thank you for answering them, Dr. Morales. Before we conclude, if there's no other questions, this has been very helpful, first of all, Dr. Morales, so thank you. I always like to give you the opportunity. I think you've had some really great nuggets throughout this whole conversation, but give you the opportunity to let the people that are watching, what would be your advice? Like if it was your wife, or if it was your kids, or if it was someone very close to you that had or was suffering from GERD, what would you recommend they do?
Well, I'd recommend to go talk with your primary care physician. I'd recommend either to go see a gastroenterologist or a surgeon. Have someone take a look at your esophagus and take a look at your stomach. Get that EGD scope. It's under sedation. It's, again, very non-invasive, and just to get a good idea of what's going on in there and how much damage is actually occurring from this acid reflux, because that heartburn is happening because there is damage to the esophagus occurring. So you want to take a look, get on some medications, try to get yourself symptom-free, lose weight, exercise, watch your diet, lifestyle modification again. And then if you're not getting any relief, really think about getting a TIF procedure. Really think about going in and speaking to somebody at least and get all the information. Because again, like we talked about earlier, it can lead to some devastating problems, and we all want to avoid that. So that's what I would recommend. Absolutely.
Fantastic. I think my favorite thing that you said tonight was ask a lot of questions. A lot of times, and the first point of care you go to is your primary care, and some of them really don't know that there's other options outside of just the medication. So ask the questions, listen, learn, come on to these TIF talks, come on to all the different talks about the different options, and then ask questions. So couldn't have been said any better, Dr. Morales. So well, again, everybody that is watching, thank you. We're here every Tuesday, and if you would like more information, you can go onto our website, which is gerdhelp.com. We also have an app that is really user-friendly, and it helps you track your symptoms. So if you're like, I'm not sure if I have chronic GERD, go on there and you can start tracking your symptoms, what foods you're eating, what's causing this or that. And it'll kind of give you a chronicle of what's happening with you. You can bring that into your doctor and say, hey, doctor, this is what's happening. It really helps them as well. If you are in the Sisseton, am I saying that right?
That's right.
Sisseton. I said it right. Sisseton, South Dakota area. You can find Dr. Morales. But if you're not on gerdhelp.com, there is a physician finder, and you'll be able to put in your zip code and or your state, and you'll be able to find a physician near you. So thank you again, Dr. Morales, for joining us this evening. Thank you to everybody who jumped on to watch. Please catch us next Tuesday for our next TIF Talk, and stay safe out there, everybody. Have a good one.
Thank you.